Mr. Khalid, the pediatric session. In this pediatric session, we have 7 distinguished guest speakers from Egypt and from USA, from Texas, and 6 panelists. We will start with the first speaker, Professor Khamis Deep from Alexandria University. Professor Khamis Deep is the godfather of pediatric orthopedic science in Egypt and in the Middle East. We are honored to be with Professor Khamis Deep in this scientific session. We will start with the talk of Professor Khamis Deep, which is the metabolic bone disease.
Allah, the most gracious, the most merciful. Dear friends, colleagues, brothers, sons, ladies and gentlemen, welcome to this international meeting. I'm coming from Alexandria, Egypt, the city of beauty, history, and civilization. This is one of the oldest monuments in Alexandria, which is the old Alexandria Lighthouse that has been destroyed by an earthquake and replaced by what is present now is the Kite Bay Castle. I'm going to show it to you in a minute. This is the beautiful Stanley Bridge in Alexandria, one of the recent monuments that has been established in 2001. And this is the Kite Bay Castle, which replaced the Alexandria Lighthouse, and the stones of this lighthouse was used to build this castle, which is still present up till now in a very good condition. This is the marvelous Alexandria Library, which is present since 2002, one of the most famous libraries in the Middle East. My talk is about a vague metabolic bone disease in a young girl. She is 12 years old, female, complaining from generalized bone aches since 1.5 years. Pain increased some 4 months ago in the April 2015. She was checked by many pediatricians, internists, rheumatologists, and also orthopedic surgeons. They requested conventional laboratory tests, CBC, ASR, CRP, ASOT, Rosewaller, anti-CCP. All were normal, except the ASOT, which was mildly high, 2019. The suggested diagnoses by the time were rheumatic arthritis, growing pains, fibromyositis, fibromyalgia, and even psychological disorders were suspected. She was given NSAIDs, penicillin, 1,200,000 units at 2 weeks interval for 2 months without appreciable improvement. Further drug therapy using analgesics, NSAIDs, antiphlogistics, gabapentin were given without response. In August 2015, the patient was checked by one of the meticulous orthopedic surgeons who asked for the first time to do an X-ray both hips and knees. There was a band-like metaphyseal and epiphyseal lucencies in both femoral heads. This is the band-like defects in the metaphysis and also in the epiphysis. More evident in the frog leg lateral view. You see the band-like defects in the metaphysis and the epiphysis. He sent the patient to me asking for help. I requested the following investigations: whole body X-rays, spine, hips, knees, ankles, wrists, hands, elbows, and shoulders. They were presenting the same metaphyseal lucencies in all metaphyses. This is the band-like defects in the radius, distal radius and ulna, more present in the ulna. The upper humeral epiphysis, and this is the also the defects in the upper tibia and lower femur. The ankle was very evident. Actually, you see the band-like defect in the metaphysis of the tibia. In oblique views show much evident metaphyseal defects. I asked also for the following laboratory tests. So many tests were done. The positive were the following. Serum alkaline phosphatase was very high, 2,301, normal up to 300. Phosphorus very low, 1.9, normal 2.525. PTH assay was very high, 882, normal up to 52. Other investigations to complete the picture were normal. The possible diagnosis is now clarified. For me, it is either a hypophosphatasia or hyperparathyroidism, primary or secondary. I requested ultrasonography thyroid that was normal as regards thyroid and parathyroid. This was very shocking to me because usually the parathyroid adenomas appear in the ultrasonography. There is no adenomas in the ultrasonography. I consulted one of the most eminent professors in radiology about other modalities that can diagnose parathyroid adenomas. He advised to do a new CT modality for our patient, which was 4D CT scan of the thyroid, parathyroid adenoma protocol. This is the picture, very big inferior parathyroid adenoma related to the left lobe of the thyroid. And another, also one superior, small parathyroid adenoma. So two adenomas appeared in the CT scan, the new modality. The findings, in short, are left inferior parathyroid adenoma measuring 18 by 27 millimeters, abutting the superior border of the left brachiocephalic vein, caudal to the left lobe of the thyroid at the thoracic inlet. Very busy area with vessels and nerves, especially the recurrent laryngeal nerve is there at that time. Left superior parathyroid adenoma 6 millimeters posterior to the superior part of the left thyroid lobe. So I'm convinced now that the final diagnosis is left upper and lower parathyroid adenomas. When I was operated upon by an eminent, highly celebrated head and neck surgeon, of course, who is very famous and can do very well these difficult cases. Operation was done in the 16th of June 2016, so some 1 year after the start of the complaints. What our friends did is excision of the left lobe of the thyroid, including the inferior big parathyroid adenoma and the posterior superior small parathyroid adenoma. Excision of the nail, or let me say the upper pole of the thymus, because it was hypertrophied also, and small two lymph nodes nearby. This is the lesion, as you see, and this is the brachiocephalic vein. After excision, see how near the recurrent laryngeal nerve the blue arrow to the site of excision of the left lobe, and see how also very close to the brachiocephalic vein. After excision, this is the nail of the thymus, and this is the left lobe, including the two adenomas. These two small things are the lymph nodes. One of the most nice things that our surgeon has did is, before closure of the wound, he requested PTH assay, which was found to be 95. It was 882. After excision, it dropped to 95. So it is a bit high, but near normal. Calcium was low. Histology, unremarkable thyroid tissue, nothing in the thyroid. Parathyroid adenomas, inferior big and posterior superior small. Thymic hyperplasia, reactive lymph nodes, no malignancy. 3 months later, investigations were done. Normal PTH, normal vitamin D, slightly raised serum alkaline phosphatase. Calcium is a bit low. Phosphorus is a bit high. X-rays, better calcification of the metaphyseal lucences. Still there, but much better calcification. 6 months later, normal calcium, normal phosphorus, alkaline phosphatase is a bit high again. PTH increased to 61 vitamin D normal. X-rays, again, better classification of the metaphysio-epithelial, especially the epiphyseal lucis has disappeared, actually. 4 months later, in April 2017, all investigations were normal. Nothing at all, only the remnants of the right metaphyseal lucences, again, nearly normal hips, wrists, normal wrists, no metaphyseal lucences at all. So complete classification of the epiphyseal-metaphyseal bands, clinically no pain. Thank you very much for your kind attention.
Thank you so much, our beloved Professor Khamis Deep, for this very interesting talk. Now we will move to the next speaker, our eminent and beloved Professor Muhammad Usama Hijazi from Benha University. Professor Usama will speak about complex lower limb case. Professor Usama.
Dear colleagues, it's a great pleasure for me to be with you here. I will present a case of a complex pediatric lower limb problem, and I will ask for opinions at the end of the session. It's an 11 years old girl, previously treated for recurrent dislocation patella, presented with lower limb problem in the form of varus deformity of the knee, flexion deformity 10 degrees, flexion range of motion from 10 to 19 degrees, 5 centimeter shortening. In the left lower limb, there is valgus deformity and flexion deformity of the knee. If you summarize the problem in this patient, it's for the right limb, varus and flexion deformity and shortening. For the left lower limb, flexion and valgus deformity. How to treat this case? If we think to treat this case, we will go to the principles of management of complex pediatric lower limb deformities to stick to the rules. Principles of management are successful limb reconstruction surgery not only relies on the skills, but more on assessment and planning before intervention. Systematic approach to assessment of a complex lower limb deformity is essential to achieve the desired outcome with lowest rate of complications. Clinical and radiological evaluation are a key of success for successful treatment. So, what are how to apply a systematic approach for such a case? There are 4 steps: understanding of the natural history of the condition, clinical assessment, the deformity in the coronal and sagittal plane, length inequality, and other lower limb, other joints of the lower limb, imaging evaluation of the deformity for direction, level, and degrees, and then we come to decision-making for correction. The decision-making for correction, either correcting the complex multiplanar deformity is much better to be staged procedure to achieve better and to lower the incidence of complication. Deformity correction, either by acute correction by osteotomy or gradual correction by guided growth. Then lens correction, and then we use hybrid technique for lens and deformity correction. Then we come back to our case. This is our case. This is the imaging evaluation of the case. The results of this evaluation for the right lower limb, there's femoral valgus deformity of about 12 degrees, varus deformity about 12 degrees to compensate the proximal valgus deformity. The mechanical axis looks good. Lower deformity femoral, distal femoral angle is 9.3. Normal distal femoral angle is about 81. This is the situation of our patient on the right lower limb. This is CT scanogram, show procurvatum deformity and extension lag of 10 degrees. Then we come to the staged approach. Staged approach, how to treat such a case. It's for my knowledge, for my limited experience in this, is right lower limb. We start by the right lower limb, then we start by the left lower limb. The parents, if we discuss the problem with the parents, they refuse to start by the normal limb because it's 5 years for the patient who is suffering from right lower limb, and they refuse to start by treating the normal limb, as they said. If we stick to the rules, we try to correct the right lower limb problem. It are varus and flexion deformity in shortening. Correct the varus, the left lower limb deformity, flexion and valgus deformity. For correction of the right lower limb deformity, we decided to correct the deformity by doing osteotomy, corrective osteotomy, and lensing procedure to treat both problems, deformity and limb length discrepancy. Then, if we finish from this, we shift to treat the left lower limb to correct flexion and valgus deformity by deformity correction either by infusiodesis or osteotomy. It's a debate to start by which, the right to start by this or to start by left to achieve a good aligned limb and then start to correct the lower limb. It's a debatable decision. The parents, if you discuss the problem with the parents, they refuse to start by the left lower limb. For right lower limb, we decide to do a correction for the deformity. After correcting the deformity, we start by lengthening. And for the left lower limb, after finishing solving the problem of the right lower limb by correcting the deformity and restoring good alignment and correction of the flexion deformity, we start by treating the left lower limb. To treat the left lower limb, there is valgus deformity. We try to correct this valgus deformity either by osteotomy or by infusiodesis. Then, with the residual varus deformity, we need later correction. So, if we plan to treat such patient, we try to start by it's an opinion, and I would like to hear another opinions from our experts. To start by correcting the right lower limb deformity by doing osteotomy, then correct limb length inequality after correcting the malalignment. Then after we finish from this, we can start by correcting the left problem, the lower limb, by correcting the valgus deformity by either infusiodesis or osteotomy. And then later on, if we need to correct this varus deformity, we will proceed. It's my planning for treating such a case. And I would like to thank you. And at the end of the session, I would like to hear the opinions of the experts here. Thank you.
Thank you so much, my dear Professor Osama Hijazi, for this very interesting case. Now we will move to the next speaker, Professor Hisham Abdelghani, Cairo University, Egypt. Professor Osama, would you please stop sharing screen? Professor Osama? Stop sharing screen, sir.
Okay.
Thank you, sir. Professor Hisham Abdelghani, Cairo University, Egypt.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, first of all, I'm very grateful and thankful for the Dr. Muhammad Al-Ashhab and the organizing committee for inviting me to give this presentation. It's my pleasure to share with you this case presentation. Mr. Chairman, I will present a case of tarsal coalition. This girl presented with varus of heel and varus of the foot over the last year. She is 8 years old. She has no history whatsoever of any paralytic problem or any history of trauma, but just this deformity and walking on the outer side of the foot. And on trying to put the toes on the foot, she has a dorsal punion. On examination, the hind foot is very rigid, uncorrectable, varus deformity. And I asked for an X-ray, and this was the X-ray appearance, a classic anteater appearance or anteater sign of the anterior process of the calcaneus, extending to articulate with the navicular. It's a classic tarsal coalition, calcaneo-navicular coalition, classic coalition, but unusually presenting with varus deformity. This is mentioned in the literature. This is not rare, but we have to keep in mind that tarsal coalition may present as varus foot and not valgus foot as we usually encounter. And on the other side, there is also an evidence of abnormal articulation between the calcaneus and the navicular. And this is also in agreement with the literature that the tarsal coalition is usually bilateral, but we treat only the symptomatic side and not the non-symptomatic side, even if there is true or very evident tarsal coalition radiologically. It is very clear in the oblique view, complete fusion between the navicular and the calcaneus, and also in the CT 3D reconstruction it is very evident. Sometimes we ask for other radiological modalities like the CT to exclude other tarsal coalitions in the foot. The decision making was to do excision and the interposition of the extensor digitorum brevis in the site of the coalition. We did a direct approach over the site of the coalition, and then dissecting the subcutaneous tissue, and then elevating the extensor digitorum brevis muscle. And here is the coalition is very evident. We ensure it radiologically by image intensifiers intraoperatively, and then we did excision of all these coalesced side. It is very important to notice that on doing the excision, we are very near to the talar head and very easy to injure the talar head. So we have to be meticulous, and we have to make the osteotome directed toward the sole of the foot and not horizontally toward the medial side of the foot to avoid injury of the head of the talus. And then we ensure radiologically, intraoperatively, that we did a hole and we excised the whole coalition, and to parallel to the superior border of the calcaneus, and just along the line between the cuboid and the lateral cuneiform. And then we put a stay suture in the muscle extensor digitorum brevis and exit this on the medial side, and then we apply tension on it to keep the muscle at the site of the coalition after excision to avoid recurrence. Post-operatively, we put the patient in cast for 3 weeks. After that, we allowed weight bearing without physiotherapy. She has a very nicely mobile subtalar joint, and in this case of varus deformity, we don't need to address the flat foot or severe valgus foot like in other types of calcaneovalgus deformity or the valgus deformities encountered with other forms of tarsal coalition. And this is the X-ray 1 year after follow-up. There are some radiological evidence of recurrence, but the patient was walking very nicely after 1 year of follow-up. Thank you so much.
Professor Hisham Abdelghani, thank you so much, sir. Now we will move to the next speaker, Professor Tariq Hassan and Shams University, Egypt. Professor Tariq will speak about congenital high scapula. Professor Tariq.
Good afternoon, dear professors, dear colleagues. Thank you very much, Professor Mohammed, for inviting me to this, and congratulations on your extensive efforts to cover all topics.
Thank you so much, sir.
I will share my screen now. I would like to discuss a rather uncommon condition of upper limb deformities, which is the congenital high scapula or the Sprengel's deformity, and in particular, how to address it with a rather simple surgical procedure. I will allow me to do a little bit of introduction before we go to the case presentation. The scapula is originally located as a sagittally oriented structure in the neck, then migrates to its coronally aligned posterior thoracic position. Failure of its descent leaves it in an elevated and malrotated position. The scapula in this condition is small and broad. It is rotated with its glenoid directed inferiorly. Very importantly, fibrous bands tether it to the chest wall, limiting rotation. And this is one aspect that we have to remember when addressing this condition. In about 40% of cases, an omovertebral bone will attach it to the cervical spine. Now, children with congenital high scapula have two significant problems. One is cosmetic, and the other is functional with limited shoulder abduction. And as we can see, the cosmetic problem is due to the high scapula, prominence at the superior-medial angle, and the torticollis. The functional is due to the fibrous bands causing scapulothoracic stiffness and as well the inferiorly rotated glenoid. Now, the surgical options vary from very simple procedures as simply excising the prominent superior angle, major procedures like the subtotal scapulectomy, and passing through the relocation procedures described by Green and Woodward. Now, the excision of the angle will only cause cosmetic improvement. The other procedures are difficult procedures causing ugly scars, extensive bleeding, with high incidence of brachial plexus injuries. Now, the vertical scapular osteotomy is a surgical option that can provide cosmetic and functional improvements. As a lot of the techniques that we are currently doing now, we are repopularizing them. It was originally described as back as 1914. Now, in this study, we did a case series study of 7 children with an average age of 8.4. They were all girls, and they all underwent the vertical scapular osteotomy as described by Campbell. We assessed using the Cavendish grading system, the global abduction, and the patient and the parent satisfaction. This is the Cavendish grading system, which ranges from 1 to 4. The patient or the parent satisfaction was done by a method similar to the visual analog scale, with 0 meaning totally unsatisfied and 5 extremely satisfied. The surgical technique is quite simple. The child is in the semi-prone position. The arm is draped free. We do a vertical incision 2 centimeters medial to the vertebral border. We divide the fascia over the infraspinatus. We expose it, and then we do subperiosteal elevation of the infraspinatus from the blade of the scapula. We then prepare our offset holes in the blade of the scapula. We then perform the vertical scapular osteotomy. We then expose the superior medial angle with the levator scapulae and the other attached muscles. We then do an extra periosteal excision of the superior medial angle of the scapula. And if the omovertebral bone is present, we then divide it at this stage. And then we put our finger to divide the fiber spans between the scapula and the anterior chest wall. This is a very important step to increase the range of motion. We then pull the lateral half of the scapular blade down, and we then tie the F-bond number 5 sutures at the offset holes, which now come out opposite to each other. We secure hemostasis. We immobilize the arm in a pouch arm sling and start pendulum exercises as early as possible. And after 6 weeks, we start physio and allow full range of motion. We had good results with improvement in the global abduction with an average gain of 50 degrees. And all patients had a cosmetic improvement with near leveling of the shoulders. The Cavendish grade improved about 1.7. Scars inevitably healed by a keloid scar, but they did not pose a source of concern to the parents. No patient had a brachial plexus palsy, and the presence of the omovertebral bar did not prevent achievement of satisfactory results. Now, these are 2 of the 7 patients. 12-year-old girl, limited abduction and cosmetic disfigurement. She underwent the Campbell's vertical osteotomy. These are the results with near leveling of the shoulders. This is pre and this is post. We can see the leveling of the shoulders. The range of motion improved from 60 degrees to 140 degrees. The second child was a 9-year-old girl. She was a more severe case with limited abduction and severe cosmetic disfigurement, as we can see. A very prominent superior medial angle and absence of the space between the neck and the shoulders. She could only achieve 55 degrees with severe swaying of the trunk. She also underwent the vertical osteotomy. She had a great improvement both cosmetically and in the range of motion. This limited study emphasizes the results that have been previously published that congenital high scapula can be treated successfully with a vertical scapular osteotomy. The procedure is relatively simple. The results are reproducible in comparison to the Woodward and the Green relocation procedures in the subtotal scapulectomy. We selected our patients not to include any syndromic conditions. This might have affected our results. The small number definitely has an implication, but we have to remember that the condition itself is rare, and several case series studies could be included in the future in a multi-center or a meta-analysis study. Thank you very much.
Thank you so much, my dear Professor Tariq Hassan, for this very interesting talk. And now we will move to the next speaker. The next speaker will be Professor Ahmed Sabit from Texas, USA. Professor Ahmed Sabit will speak about radial neck fractures in children. Professor Tariq, would you please stop share screen?
Yes, I will. I've stopped, yes.
Hello, everybody. It's my pleasure to present some of the complex cases in children fractures with you guys. My name is Ahmed Sabit, one of the orthopedic surgeons. Today I'm presenting 3 different cases that present the spectrum of radial neck fracture in children. See the X-ray on the left, X-ray in the middle, X-ray on the far right, different types of radial neck fracture. Case number 1. This is 11-year-old female who fell on the right elbow. The patient severe pain, limitation of movement, and the X-ray showing fracture of the radial neck. You see the amount of displacement, so the decision to treat this fracture non-operatively because of the amount of displacement. So you can see the X-rays of the cast with alignment, with maintained alignment of the radial neck. So this fracture was continued to treated non-operatively without the need for surgical intervention. So the fracture went into healing, and the patient maintained the range of motion of the elbow flexion extension and a forearm rotation, supination, and pronation. The patient did well with non-operative management. Comparison to case number 2 with the different type of fracture, and the treatment was different as well. 11-year-old female jumping from trampoline in May 2020 during the COVID time, and the patient developed severe, the patient has no compartment syndrome, and the patient is neurovascular intact. So what you do in this case is, what are the treatment options, operative, non-operative, and what are the decision-making points in this fracture? So you see, if you look at the X-rays, and on the preoperative X-rays, you can see the patient has severe displacement, and that we decided to proceed with. So this is the treatment options. We treat to this fracture using closure reduction and percutaneous pinning, and we use a metazoa technique using the flexible nails to catch the radial head with the tip of the flexible nail, and then rotate the flexible nail 180 degrees, and this will reduce the radial neck in its original position. However, because of the severe displacement, this technique was not efficient. We have to augment this technique using a stymie pin, 2/0 stymie pin, into the fracture site to leverage the fracture. And we were able to do this, and then we advance the flexible nail for fixation. So, and then we use a flexible nail for fixation, and the reduction was maintained during the surgery. You can see the follow-up images. The reduction was maintained using the flexible nails. So these are the images showing the healed fracture after flexible nail removal. Case number 2. This is a complex elbow case as well, showing this is a 7-year-old female fell off the chair in May 2020. The compartment are soft and compressible. Patients are neurovascularly intact. These are more images of the forearm and X-rays of the elbow. More images of the fracture to get better understanding of the injury. Of this fracture, just like a Montegia fracture dislocation, and this image showing different the classification: type 1, type 2, type 3, type 4. This is considered as type 4 because of the fracture through the ulna, the fracture of the radial of the radius. And the most common type in the children is type 1 with apex anterior ulnar fracture with anterior dislocation of the radial head. So what do you do in this case, and what are your treatment options in this case? And we decided to treat this patient operatively because the amount of displacement and the amount of radiocapitellar joint incongruity. We started with the ulna first for fixation. So we use a physalis sparing approach using flexible nails to fix the ulna, and we advanced the flexible nail under fluoroscopy, and we're able to get the ulna under reduced with the flexible nail, and then we noticed marked improvement in the position of the radial head. As you can see in this picture, the reduction of the radial head using the flexible nails for the ulna. So these more images and different views showing the reduction of the radial head, of the radial neck after fixation of the ulna. More images showing anatomic reduction of the ulna and the reduction of the radial head. The patient was splinted to help with the maintaining the reduction of the radial neck. More follow-up images show maintenance of reduction of the radial head and maintain the reduction of the more follow-up images to show the reduction of the ulna and the reduction of the radial. More follow-up images. And this is the x-rays after hardware removal. Thank you so much. I'm happy to answer any questions. Thank you so much.
Thank you so much, Professor Ahmed Sabit, joining us from Texas, USA. Now we will move to the next speaker, Professor Ahmed Shaukat from Benha University, Egypt. Professor Ahmed Shaukat will speak about neglected elbow fractures in children. Professor Shaukat.
Good afternoon. Welcome, everybody. My name is Ahmed Shaukat Rez, Professor of Orthopedic Surgery, Benha Faculty of Medicine. It is a great honor and a pleasure to exist and participate in this scientific festival with you all. I will present cases with neglected elbow fractures in children. Elbow fractures are either supracondylar or lateral condyle fractures, and the golden rule for management for supracondylar fracture is either urgent or emergent closed reduction and percutaneous vening. The same with lateral condyle. The golden rule is early closed reduction or open reduction internal fixation according to stability and displacement of the fracture. So no place for delay in pediatric elbow fractures. But unfortunately, sometimes we face it. I mean, we face neglected elbow fracture. Case 1, 11 years old male child, 27 days old, displaced extension type supracondylar fracture with early callus formation as shown in this X-ray. The patient had also ulnar and radial nerve concussion, presented with a painful stiff elbow in extension with volar abrasions and crusts. What does the literature say? American Academy guidelines published in 2011 defined the neglected supracondylar fractures as fractures presented for treatment after 14 days of injuries and had already started the biological process of healing with early callus formation. Late surgical intervention in neglected cases is challenging and risky, with many disabling complications such as myositis ossificans, completely ankylosed elbow, stiff elbow, or iatrogenic neurovascular injury. But if left untreated, the prognosis will be catastrophic. For this case, open reduction and internal fixation was done through the triceps sparing approach. This illustration demonstrates the approach. The approach starts by exposure of the ulnar nerve behind the medial epicondyle, then retracting the whole bulk of the triceps laterally after freeing or releasing the triceps muscle from the medial intermuscular septum. On the other side, developing the interval between the lateral intermuscular septum and the lateral border of the triceps, then retracting the intact triceps muscle to the level of the lateral condyle. By doing these both steps, now we can access the lower part of the posterior surface of the humerus without any obstacle, managing or handling with the displaced fracture, achieving reduction and fixation. This is the post-operative X-ray for the presented case, more or less accepted reduction and stable fixation using 4 wires, 2 medial and 2 lateral wires for adequate stability. 15 days post-operative, there is improvement in the soft tissue condition, and the patient was encouraged to start active range of motion even before the stitch removal. Progression of the range of motion and the improvement of the neurological insult over the first 2 months post-operative. 75 days post-operative, this is the X-ray, complete consolidation of the fracture in an accepted position. 6 months follow-up, final X-ray, and this is the final functional result with improvement of the motor power of the hand and wrist with accepted elbow range of motion. Case number 2, male child 12 years old, neglected 22 days, supracondylar fracture, flexion type with early callus formation also, very good skin condition, no neurovascular complication. This is the X-ray. You can see there is a flexion type with complete of ending of the distal fragment with early callus formation seen in the or if was done through the triceps approach, the same approach as in the previous case. This is the post-operative X-ray accepted or near anatomical reduction and stable fixation by column fixation or medial and lateral wire fixation. You can see in the first photo, in the first intraoperative photo, that all the procedure done and completed without touching or injuring the triceps muscle. The last photo on the right side, this is the post-operative wound 2 weeks after surgery. 45 days post-operative, there is progressive union of the fracture with improved range of motion. You can notice that the patient achieved this range with the wires still in place. These videos demonstrate the importance of encouraging active range of motion and the progression we achieve with the wires still in place between 25 days post-operative, 45, and the last video was recorded 75 days post-operative for near complete restoration of the motion. 6 months follow-up. This is the last X-ray, and this is the last clinical or functional result of the case number 3. Case this for a neglected lateral condyle fracture prevented in a male child 5 years old, neglected 112 days, 3.5 months, prevented with painless stiff elbow with very good skin with no neurovascular complications. This is the X-ray. What does the literature say about lateral condyle or neglected lateral condyle? Neglected lateral humeral condyle fractures are unrecognized, misdiagnosed, or mismanaged fractures that present later than 21 days or 3 weeks after injury. More recently, Giovanni classified neglected lateral condyle fractures as delayed union if presented less than 3 months from injury, or non-union if presented more than 3 months from injury. Many authors highlighted the problem of intrinsic instability of lateral humeral condyle non-union in children that leads to progressive deformity with high risk of delayed cubitus valgus and tardial nerve pulse. So there is a current consensus about late surgical intervention in neglected cases with non-union. But unfortunately, late surgery, 6 to 12 weeks after injury, is risky. It could damage the blood supply of the fragment, cause EVN of the lateral condyle, cause premature physeal closure, and end with non-united stiff edge. Moreover, and unfortunately, there is no clear guidelines for surgical decision making, no clear classification for neglected fractures of the lateral condyle, and the treatment outcomes of such a fracture in children are underreported, as there is only approximately 450 cases described in the literature. Back to the case, complete radiological workup, AB, lateral and oblique views, to document that this is a non-united lateral mass, and to be more sure, CT is mandatory. The standard lateral approach was used. The section was minimized posterior, and release of the fragment started from proximal to distal. Then a reduction clamp was put on the metaphyseal fragment. Then the first wire was passed. Another wire to add fixation. Then a cannulated drill bit inserted, slided on the wire. Then a cannulated screw holding the metaphyseal fragment was inserted. Additional third wire directed from posterior to anterior engaging the metaphyseal fragment was inserted. This is the final CR images of the case, more or less accepted reduction and stable fiction. The immediate post-operative X-ray. Immediate post-operative CT is mandatory to assess the adequacy of reduction. This is the case after 60 days post-operative. There is more or less promising union. The third wire was removed for early loosening and vein tract infection. All wires were removed 2.5 months post-operative, and this is the X-ray. CT was done to ascertain the union. Regarding the range of motion, there is improvement over the post-operative period. Is 2.5 months post-operative, 4 months post-operative, more progression, and by the 6th post-operative months, there is near full elbow range of motion. This is the final X-ray of the patient 10 months post-operative after removal of all the implants, anatomical reduction and fully consolidated fracture with still reserved mass. This is the last CT after complete removal. This is the functional result after 1 year post-operative, denoting complete restoration of the elbow range of motion. The take-home messages: when there is no hope for satisfactory results with non-surgical intervention, surgery, although difficult, is a must. Proper surgical approach and careful soft tissue handling with limited dissection are key factors for a successful outcome. Don't rush for early wires removal, but strongly encourage early and progressive active range of motion. The pediatric elbow is not a no man's land. Satisfactory results still could be achieved in lately presented neglected cases. Thank you very much for your attention and your time. Thank you.
Thank you so much, Professor Ahmed Shawkat, for this very interesting talk. Now we come to the final and speaker and last speaker in this session, our beloved professor and our dear professor, Professor Amr Azzam from Neuromotor Institute. Professor Amr Azzam will speak about pediatric distal both bone forearm fractures. Professor Amr.
At the beginning of my case presentation, I present my deepest gratitude to the Professor Muhammad Al-Ashhab participation in a great
Professor Amr, I'm sorry, the voice is interrupted.
Meeting. I'm starting my share. My name is Amr Azzam of Neuromotor System. I can see the video of my presentation.
Yes, yes, it's obvious, sir.
Yes. Yes, my name is Amr Azzam, a consultant of orthopedic surgery in the National Institute of Neuromotor System in Cairo, Egypt. My talk today is about the pediatric.
Professor Amr? Professor Amr?
Both bone forearm fracture and the orthopedic, the post-reduction films that given for us with him, we can notice this is lower ulna is something happening here, but unfortunately he was casted in a short arm cast, and then after 4 days we have seen him in the long arm cast. I don't know why for this. We have a lot of comments for such a case, and this is our highlight for the presentation. So our epidemiology of such a case is about to be 1.5 per 100 children per year with such a fracture, representing 40% of all pediatric fractures with a seasonal variation during vacations, and traditionally was called a pronator quadratus, but we have to highlight the difference. This was the mechanism of injury described by bayonet, the dorsal bayonet expected to be a dorsal type or reverse type. Here we have the bayonet shape, this is a World War II rifle, and this is the shape for our case. But we have a dorsal bayonet with the intact dorsal periosteum and a volar bayonet with the intact volar periosteum. But unfortunately, our case today is talking about the classification of the Galeazzi variant as well. This is a dislocation variant. Here we have the fracture lower radius, not in the same line or the same level of the fracture ulna, with a short ulnar distal ulnar segment described by Landfield 1991. Here we have the importance of highlighting the periosteal and periosteal sleeve that will block the reduction of such a case in the ulnar part. we may have associated injuries like the carpal or the medial or ulnar nerve neuropathies, and the elbow as well, a floating or supracondylar as floating type, as Professor Ahmed was talking about, the supracondylar fractures. The clinical picture, what might be a history with a history of trauma, with the pain, swelling, deformity, might be a bayonet or not, but with the limited wrist movement and distal pulsation has to be examined, neurological examination as well. What about the radiological assessment? We have to do a long film, as we are going to describe, with an additional elbow or wrist views when suspecting another injury, like in these X-rays. So the treatment modalities might be a closed reduction with a cast with internal fixation as well, internal fixation variables with K-wires, external fixation with a or titanium nail to restore the length, alignment, and rotation for both the ulna and radius, and open reduction with a plate for the unstable or neglected cases, which is very rare. And the closed reduction might be like this maneuver, two-man maneuver described with a general anesthesia, increasing the deformity to 90 degrees, and then closed reduction, or reduction with a K-wires, multiple K-wires insertion in the fracture site to reduce every bone in the same, two bones in the same time. And regarding the closed reduction, we might use the 3-point fixation in the cast. We are not going to describe it as either in the volar or dorsal, so we have to do an above elbow cast, not a very short cast as we have seen in this case. The quality was a debatable case. So the Bruder described this debate, and he prefers that we have to see the free spaces around the cast with a close follow-up with a weekly basis. So the very important indication for such a case to prevent the debate or the mix, or first, the fracture radius not at the same level of the ulna. This is a Galeazzi variant, not a lower both bone 4R. So also in the small ulnar fragment, and as in we have seen in our case, and unstable ulna, which might be wedged or butterfly or multifragmentary as well in the radius. So also the severe swelling precluding the circumferential cast or the open fracture with floating elbows, polytrauma, or irreducible fractures in the closed method, lastly with a neglected or loss of reduction. About the fixation modalities might be a 2K wires from the ulnar styloid and crossing wires on the lower radius, as described by Crawford 2012, and close reduction with internal fixation by Nancy, or titanium elastic nail in the ulna, in the same time by the wires on the lower radius. We have to highlight the compartment syndrome in such a case. We have to have a very close follow-up with a clinical and radiological basis. So the complications, what we may have seen, that's malunion, non-union, loss of reduction, vascular as a compartment syndrome with a very important highlight for these fractures, neuropathies, median or ulnar nerve anastosis. Let's go back to our patient. We have seen him 18 days post-trauma. We started our treatment modality, and here we have these casts. We don't know why he have done it. And the radiological assessment start with us with the long films. We found there is no acarpal or lower humeral fractures. And the very important tip is a comparative X-ray with a contralateral side to highlight the ulnar radial tilt, radial inclination as well, and to know that's the operative assessment image. And this is a very important image on the right side. We have a complete loss of reduction of the lower ulnar fragment. We started closed reduction, but with irreducible ulna. We have done a dorsolateral minimal approach and removing the soft tissue inside the fracture with a 2K wire podocephalic from the ulnar styloid and 2 crossing wires in the radius as well, in spite of the radius started union, but we preferred it to keep the reduction and to maintain the interosseous integration for such a stability of this fracture. And the follow-up was with a weekly basis, but we can see here the 4th week post-operative started union on both ulna as well. And the last follow-up was 6 weeks we have seen in a complete union of the radius as well as the ulna. We removed the K-wires and started the physiotherapy under our supervision. Here, department of physiotherapy, functional deviation, but limited supination with a 20 degrees limitation. He's on the physiotherapy till now. For this case, to conclude, it's the lower radius postbone forearm, either the short segment of the ulna or in the same level of the radius and ulna, with relative highlighting on the loss of reduction, this fracture necessitating a close follow-up in a weekly basis, and lastly, the supervised physiotherapy program. Thank you very much.
Thank you so much, our eminent professor, Professor Amr Azzam. Now our panelists, we have 10 minutes for discussion with our distinguished guest speakers. Any questions for our speakers or any comments?
دكتور محمد ازي حضرتك؟
دكتور شنبي.
اخبار حضرتك؟ الله يخليك، شكرا جدا على الميتنج ده.
الله يخليك.
مش ممكن يبقى معانا دكتور خميس من غير ما عكسه يعني. دكتور خميس بيه ازي حضرتك؟
دكتور خميس منور دايما
كبير. مساء الخير.
سعيد اني اشوف حضرتك ودايما منور كده وبتسعدنا حضرتك.
انا اكثر سعاده حبيبي.
الله يخليك. ليا سؤال عند حضرتك. البيوبسي بتاع الاكسايزد ماس طلع ايه؟
طلع ان الثيرويد تيشو از نورمال، مفيش اي بروبلم فيه خالص. طلع فيه هايبرتروفي في التيل اوف ذا ثايموس جلاند، ودي في الغالب بيبقى فيها ساعات حاجه تيشو something like the parathyroid adenoma tissue، فتشال التيل بتاعها، الدكتور شاله يعني اللي هو بتاع الجراحه، وما عرفش يشيل اللي فوق واللي تحت كومبليتلي، خصوصا اللي فوق، فاضطر يشيل الليفت لوب اوف ذا ليفر اوف ذا ثايرويد كله، بما فيه السمول ادينوما فوق والبيج ادينوما تحت.
لكن
حاسب قوي زي ما انت شايف على
البيوبسي ما طلعش اي ادينوما.
طلع ادينوما طبعا، طلع بيج، انا كاتب في الريبورت بيج فيري بيج باراثيرويد ادينوما lower one in relation to the lower part of the left lobe، واحده very small على الابر بول بتاع الليفت لوب اوف ذا ثايرويد. فالاثنين طلعوا موجودين، واتشال كمان التيل اوف ذا ثايموس والتيل اوف ذا ثايموس، وشال برضه 2 ليمف نودز كده كان شاكك فيهم، ما طلعوا نورمال، ما فيش حاجه خالص.
هي انا بسال حضرتك كده السؤال لاني الكلينيكال بيكتشر بتاعت العيانه واللابس بتاعتها ماشيه اكتر مع انها فيتامين دي ديفيشنسي ريكيتس، ودي سكندري هايبر بارا لعده اسباب.
ايوه،
السبب الاولاني 800 في الباراثيرمون مش العالي قوي بتاع البرايمري هايبر باراثيروديزم، ما كانش فيه هايبر كالسيميا. دايما في الاولدر ايج جروب ما بيحصلش كابينج مع الريكتس، بيحصل الوايدنينج اوف ذا فايسز بس. العيانه بعد العمليه طبعا الدكتور لازم بعد العمليات دي بيدي كالسيوم عشان ما يحصلش هايبوكالسيميا، فبيدي كالسيوم وبيدي فيتامين دي وبتاع، فالعيانه اتحسنت بسبب كده. ومش بس كده، كمان لما اتعمل لها البوست اوبرتيف فيتامين دي اترفع، مع ان الفيتامين دي ما كانش اتعمل بري اوبرتيف. لما العيانه بقى استمرت ومشيت من غير علاج، الفيتامين دي رجع قل تاني ووصل 11 ده is not normal, it is very very low، فهترجع تاني برضه.
احنا فكرنا في القصه دي كويس قوي، وبعدين اشركنا معانا الناس بتوع الاندوكرينولوجي في الكليه عندنا، وقالوا لنا ان الفيتامين دي ده نازل بسبب ان الباراثورمون لما بيعلى it will stop hydroxylation of the vitamin D2 to vitamin D3 in the kidney. فلما بيحصل كده، طول ما يعلى الباراثورمون لازم ينزل الفيتامين دي، لانها خدت قبل كده، قبل ما نعمل اي بايوبسي او انفستيجيشنز او كذا، خدت فيتامين دي كتير قوي، وخدت برضه كالسيوم وخدت فوسفورس، لكن الموضوع كله طلع very big lower parathyroid adenoma و very small one فلما اتشالوا تلاحظ حضرتك ان بعد ما اتشالوا على طول اول ريبورت، اول تحليل طلع ان الباراثورمون نزل بسرعه. فمعنى كده ان المشكله مش فيتامين دي كسكندري. 2 بيج ادينوماز، واحده كبيره وواحده صغيره، فدول اعتقد يعني تو ماي مايند ان هم دول سبب المشكله من اساسه يعني.
اوكي ثانك يو سير.
ثانك يو سير. شكرا على المعاكسه.
الله يخلي حضرتك.
الناس كلها بتحب حضرتك دكتور خميس، ما حدش.
وانا والله بحبكم والله وربنا يعلم
سيادتك يا استاذ. Any other questions? Any other questions to all our guest speakers?
ايوه دكتور محمد شهاب.
اتفضل يا فندم. اتفضل يا فندم.
دكتور مازن.
اتفضل يا دكتور مازن. اتفضل يا فندم.
طبعا بشكر جميع اساتذتنا، بروفيسور خميس الدي، بروفيسور احمد ثابت، بروفيسور احمد شوقت. Thank you very much for this nice talk. I have a question for Professor Ahmed Thabit. Dear sir, what's your tip while you are doing joystick K-wire fixation in one of your cases to avoid nerve injury, posterior interosseous or something like that?
Ahmed Thabit, you are with us, Professor Ahmed Thabit. I think Professor Ahmed Thabit is not present. عنده طيارة من تكساس رايح شيكاغو، فقال لي أنا في الوقت ده أنا هسجله بس للأسف مش هقدر أكون موجود.
Okay.
I'm sorry,
Thank
sir.
you.
I'm sorry, sir. Any other questions? We have another 3 minutes. Any other questions?
ايوه يا باشا. السلام عليكم دكتور محمد بيه.
اتفضل دكتور عمرو. اتفضل يا استاذ.
زي حضرتك. انا عايز اسال الدكتور هشام. السلام عليكم جميعا. طبعا يعني دكتور عزيز، يمكن تip صغيره بسال عليها. ليه ما استخدمناش السبكوتينيوس فات as an interposing soft tissue بدل التندن؟
اهلا عمور، ازيك حبيبي؟ لان في المنطقه دي مفيش سبكوتينيوس فات، فهضطر افتح انسجن تاني في مكان تاني عشان اخد سبكوتينيوس فات. فما دام موجود عندي الماسل هنا وايزي وفي نفس المكان